Okay, now let's look at osteoporosis and bone pathology. So in this video, we'll look at the definition of osteoporosis, and after that we'll also look at the pathophysiology of osteoporosis, how osteoporosis occurs, and then from there we'll now look at the clinical features, how it will present. Then from there we'll look at the investigations. Okay, if someone comes with this condition, what should we do in order to come to the diagnosis of osteoporosis? So osteoporosis is simply defined as the osteopenia that is severe enough to significantly increase the risk of fracture. So it is defined as osteopenia. So osteopenia is simply the decrease in bone mass. So the mass of the bone is decreased. So now this decrease in bone mass, which is severe enough to significantly increase the risk of fracture, is what we call osteoporosis. Okay, now we can also define osteoporosis radiographically. So radiographically we can define osteoporosis to be bone mass which is at least 2.5 standard deviation below the mean peak bone mass. Okay, so that is, if we have the average or the mean of the bone mass of normal individuals. Okay, so we get the average of the bone mass, and then we'll come up with the average, which is the single figure. Then from there, now from that single figure, if we have someone who has a standard deviation below 2.5 below, so if you have 2.5 below the mean, which is the average, then we are going to consider that to be osteoporosis. Okay, that is 2.5 standard deviation below the mean of peak bone mass. That will be considered to be osteoporosis radiographically. Okay, so osteopenia, we said it's simply the decrease in bone mass. Okay, so this decrease in bone mass should be 1 to 2.5 standard deviation below the mean. Okay, so if it goes beyond, or that is 2.5, then that will be called osteoporosis. Okay, so now this condition, which is osteoporosis, can be localized or it can be generalized. So generalized, that is, it can involve the entire skeleton, or it can just be in a few bones. Okay, so now what are some of the causes? What can cause this osteoporosis? So the causes can be secondary, so it can be due to other conditions, secondary to a certain condition, or they can be primary. So under secondary causes, we have endocrine disorders. So endocrine disorders, these are disorders which involves hormones. Okay, so elevation in hormones or decrease in hormones, such as the hyperthyroidism, where we have increased the secretion of T3 and T4. Those are thyroid hormones. Okay, so under hypothyroidism, we are going to have osteoporosis. And then we have gastrointestinal disorders such as malnutrition. So these are secondary causes. Okay, so due to malnutrition, someone can end up having osteoporosis. And apart from that, we have drugs. So drugs such as corticosteroids can also cause osteoporosis. Okay, and then apart from those secondary causes, we have primary causes. So the primary causes, these ones are not secondary, are not caused, the osteoporosis is not caused by an other condition, a different condition, but it occurs primarily on its own. Okay, so these conditions, we have the most common ones we have senile osteoporosis, which is due to aging. And then we also have postmenopausal osteoporosis or postmenopausal types. Okay, so those are the causes of osteoporosis. We have secondary and we have primary causes. Under secondary causes, we have endocrine disorders such as hyperthyroidism, and we have gastrointestinal disorders such as malabsorption, and we have drugs. So drugs such as corticosteroids can lead to osteoporosis. Then under primary causes, we have two types, which are senile osteoporosis, which is observed in aging, okay, and then we have postmenopausal type. So those are the most common ones. Now let's move on to the pathogenesis. So the pathogenesis, we have different causes of osteoporosis. So the pathogenesis will be based on what is causing the osteoporosis. For example, if it is age-related, then we are going to explain the pathogenesis in relation to the age. And then we can also explain the pathogenesis in relation to the physical activity, the genetic factors, calcium, nutritional state, and hormonal influences. So I'm going to explain the pathogenesis in relation to these causes of osteoporosis. Okay. So under age-related changes, what happens is that we have the osteoblasts. So in the formation of bone, we have these osteoblasts, which really plays a very significant role. So we have the osteoblast and the osteoclast. So the osteoblast as someone gets older, or in older individuals, they reduce in proliferation and biosynthesis. Okay, so what really happens here is that the osteoblasts are the ones which are responsible for bone formation. But in other individuals, they have reduced proliferative and biosynthetic potential, and they also have reduced response to growth factors, okay, as compared to younger individuals. So the net result, which is the result, as a result of reduced proliferation and biosynthesis, and also reduced response to growth factors, the result will be now diminished capacity to make bone. So bone formation will be reduced, okay, due to those factors, okay. And this type of osteoporosis is called senile osteoporosis, okay. So and it is characterized by low turnover osteoporosis, okay. So apart from age-related changes, which is seen in older individuals, where we have reduced proliferative and biosynthetic potential, as well as reduced response to growth factors of osteoblast. We also have another pathogenesis, which is related to physical activity. So reduced physical activity can also lead to osteoporosis. But how? So what happens is that the decreased physical activity that is associated with normal aging contributes to senile osteoporosis. Okay, that is the mechanical forces they stimulate normal bone remodeling. Okay, and this is evident by bone loss in an immobilized or paralyzed extremity. So when you compare an immobilized limb to the one which the one which is involved in exercises or physical activities which mechanically involves forces like lifting, jumping, all those physical activities. When you relate to someone who does those activities and someone who has an immobilized limb, you are going to find that the one which is involved in those mechanical forces, activities which involve mechanical forces, will have more bone density. The bone density will be more than the one which is mobilized. So that is what it means when they say reduced physical activity. So reduced physical activity will also lead to what we call senile osteoporosis. okay, by this mechanical mechanism of mechanical force, okay, as we compare it to an immobilized or paralyzed extreme. Okay, now the type of exercise which will lead to have which will lead to increased bone density are different. Okay, so we have resistance exercises such as weight training. Okay, these are more effective stimuli for increased bone mass than repetitive endurance activities such as bicycling. So the exercise or the physical activity which will lead to increased bone mass are those ones which involves weight training, okay, or what we call the resistance exercises are the ones which are good, okay, which will lead to bone mass increment as compared to those endurance activities such as cycling. So these ones won't stimulate the bone to the formation of bone. Okay, so we also have genetic factors. So genetic factors here we're talking about the single gene defects in the LRP5 mutations. So these accounts for a small fraction of osteoporosis. Okay, so these genes are involved in the formation of bone. Okay, they're involved in formation of bone. So if we have a mutation in these genes, then what will happen is that there will be more bone resorption than bone formation. So that will lead to osteoporosis. Then another pathogenesis in terms of calcium nutritional state, we know if you reduce intake of calcium, calcium is involved in bone formation. So calcium deficiency, okay, and apart from calcium deficiency, even increased parathyroid hormone concentration, and as well as reduced levels of vitamin B also may play a role in the development of senile osteoporosis. That is, calcium is involved in formation of bone, and calcium absorption is mediated by vitamin D. So if you have calcium deficiency, then bone formation will be affected, and that will lead to low bone density, which is called osteoporosis. Okay. And apart from that, we have hormonal influences, and this is observed in postmenopausal women. Okay, so after menopause, there will be reduction in the bone mass. Okay, there will be reduction in bone mass as that is 2% of cortical bone will be reduced every year. Okay, then 9% of medullary bone will be reduced. Okay, then what is most significant here is that estrogen. So in postmenopausal women, there is decrease in estrogen levels after menopause, and then what will happen is that this decrease will lead to increased resorption, bone resorption than formation. Okay, so if we have high bone resorption as compared to bone formation, that will lead to high turnover osteoporosis. Okay, so 40% of postmenopausal women are affected by osteoporosis. Okay, this is because, as I've already said, estrogen increases secretion of inflammatory cytokines. So in these cytokines, which are secreted by monocytes, they stimulate osteoclasts. Okay, so these osteoclasts are the ones which breaks down, they resorb the bone. Okay, instead of forming the bone, what they do, they resorb the bone. So if they are activated by these cytokines, which are produced due to reduced estrogen concentration, what will happen is that the bone density will reduce. Okay, so the osteoclast will be recruited, and the activity they will be recruited due to the increase in the activity of rank L and diminishing expression of OPG. Okay, so what is happening here is that in the bone we have what we call osteoblasts, which are the stromal cells. So these osteoblasts, they have the rank ligand, okay, on their surface. So once they are activated, what they will do, they will lead to formation of osteoclast, or they will activate the osteoclast precursors. Okay, so these osteoclasts are the ones now which will lead to bone resorption. Okay, they will break down the bone. But at the same time, we have the OPG, which are the osteoprotegerin, which inhibit the rank ligand from binding to the rank receptors on the osteoclast. Okay, so the osteoblast, they'll bind the ligand on the osteoblast to bind and activate the osteoclast. Then once the osteoclasts are activated, they will start the process of bone resorption. But now on the same osteoblast will produce at the later stage what we call OPG, which is osteoprogerin, okay, which will block this rank ligand from binding to the rank receptor on the osteoclast, thereby inhibiting the process of inhibiting the activation of osteoclast, which will lead to bone resorption. But now once they are inhibited there, then the osteoclast won't resorb the bone. Okay, so now the fluctuation or the difference in the concentration of OPG and rank ligand will lead to either formation of bone or resorption of bone. So if we have more of rank ligands, then they will activate the osteoclast, which will resorb the bone. If we have more of the OPG, then they will inhibit these ligands from activating the osteoclast, and what will result is bone formation. So that's what happens here. And these cytokines which activates the osteoclast, we have interleukin 6 and interleukin 1, and we also have tumor necrotic factor alpha. So these are the cytokines which will stimulate or activate the osteoclast recruitment and activity. Okay, so that is what happens under hormonal influences. So now, this diagram here also explains the same thing. We have reduced levels of estrogen. So we have reduced levels of estrogen, which will lead to increased resorption and reduced formation. And that what will happen is that we are going to have high turnover osteoporosis. So now, morphology. So the hallmark of osteoporosis histologically are going to have a normal bone that is decreased in quantity. So this is a normal bone, but now the quantity here in that case has been reduced. Okay, so now the clinical features. So the clinical features, someone who has this condition will present with a back pain due to vertebral fractures. So the bone quantity is reduced. So these patients who have will be prone to fractures. So in the vertebrae, if we have fractures there, then they'll present with the back pain. Then we are going to have increased kyphosis. So kyphosis, you know, the vertebrae should supposed to be upright like that. Then in kyphosis, you are going to have the vertebrae which is like a hanger, okay, instead of being upright like this, then you are going to have something like a hanger. Okay, that is kyphosis. Then height loss. So the height also will reduce. Why? Because let's say this is a vertebral bone, but in osteoporosis, the quantity will be lost, like the way it is here. There will be resorption of minerals from the bone. Then due to the weight or the force, the bone will be compressed. Okay, the vertebral bones will be compressed, and at the end of the day, the height will also reduce. Okay, so now under investigation, what should we do in order to diagnose this condition, which is osteoporosis? So the first thing which we can do is plain x-ray. So plain x-ray will just show some fractures in the bones which are affected. Like in this x-ray here, we can see the bones, the vertebral bones here are normal, but when it comes to this one, which is here, you can see there is compression. It has been compressed. Then here we can see there are fractured vertebral bone. So that is a plain x-ray. But a gold standard for diagnosis of osteoporosis is DXA, which is dual energy x-ray absorptiometry. Okay, which this one now, it will show even the concentration of minerals in the bone. Okay, the bone density as well will be shown. So this is the one which is done here. So it will also show the ranges and even the density and the quantity of minerals in that bone. So this is a gold standard which is used in the diagnosis of osteoporosis. So thank you so much for watching. Don't forget to subscribe, like, and share